Okay, welcome. We still have folks trickling in from our waiting room into the webinar, but we will get started. Welcome to today's webinar from the ADA Health Policy Institute. The focus of today's webinar is on how COVID-19 is impacting dental care delivery in public health settings. My name is Marko Vujicic. I'll be the moderator for today's webinar. I serve as the Chief Economist at the ADA, and I'm the Vice President of the Health Policy Institute. We have a very distinguished panel joining us today. You're going to see them live towards the latter half of today's webinar, but let me just quickly introduce them. Presenting the research that is going to kick off today's webinar is Chelsea Fosse. Chelsea is a dentist and a thought leader in oral health and a researcher in health services focused on oral health. We are extremely lucky. She recently joined our team at the Health Policy Institute, where she serves as a senior health policy analyst. Chelsea will be walking through our newest research to kick off today's webinar. Next, we're privileged to have two panelists joining us from the front line, so to speak. Sam Wakim. Sam is the Chief Dental Officer at Zufall Health Center. He's based out of New Jersey. Thank you, Sam, for joining us today, as well as Elizabeth Simpson. Elizabeth is a dentist at Meridian Health Services in Indiana. So we're going to have lots of time for panel discussion and audience Q&A as well. As usual, we have our talented HPI team in the background helping us out. Adriana Menezes, who serves as our Director of Operations, and Sylvia Zeno, who's our Manager of Administrative Services. So let's get started. I'm just going to give a quick overview before handing it over to Chelsea. Those of you that have been following our work, we've now had several waves of data focusing on dentists in private practice. We basically instituted a bi-weekly poll in mid-March when the shutdown began. I won't spend too much time on this, but it's a healthy response rate. It's a healthy number. We've been tracking what's going on in private practices every 2 weeks, and we've been reporting on that every 2 weeks as well, and the reports are all available. In addition, we've done some research focusing on dentists in public health settings. We've had 2 waves of data collection. We're going to continue doing that on roughly a monthly basis. And today's focus is presenting the most recent data, which are from the week of June 29th. And again, similar core measures as in our private practice survey, as Chelsea will show you. What's the status of your clinic? What's the volume of patients? What's your employment status of dentists who work at the FQHC or health center, et cetera. And as well, we have thematic questions of the week. You'll see there are lower numbers, but again, pretty healthy response rate. Not to get into too much detail, but this was somewhat of a snowball sampling, but we're still happy to have a pretty healthy number of responses through both waves of this survey. So with that, I'm going to hand it over now to Chelsea to walk us through some of the key findings. And remember, all questions through the Q&A chat. And as usual, we'll be providing the PowerPoint and the recording by the end of the week. Chelsea, over to you, and walk us through some of the key findings from the second wave and how this compares to the first wave.
Great, thank you, Marko, and thanks again to everybody for joining us today. We're going to begin by looking at some of the core questions on clinic and practice operating status, patient volume, collections, and PPE. The top portion of this slide represents dentists in public health settings, while the bottom portion is dentists in private practice. So as mentioned and shown here, we've done 2 waves of data collection with our public health panel, and our private practice panel has been surveyed on a bi-weekly basis. Throughout the brief presentation, I'll be referring to our public health panel as those in health centers, clinics, and FQHCs, but we know that this is a very heterogeneous group working in a wide variety of settings, so apologies if my terminology does not exactly reflect your employment situation. So now looking at those bar graphs, green indicates open and business as usual, yellow is open but lower patient volume, orange is closed but seeing emergencies, and red is outright closed. Please note that our use of as usual does not imply that these practices are operating just as they would in a pre-COVID environment. It does not mean that they're neglecting to follow recommendations by the CDC or others. Our use of as usual is just in terms of operating status. We see that there were fewer clinics that closed completely compared to private practices during the shutdown phase. And from more recent polling, there's a greater proportion of public health settings that are remaining on emergency only or open, but seeing a lower patient volume. So a lower proportion of dentists in public health settings are reporting business as usual compared to those in private practice, at least right now. With our panelists, we'll discuss why this might be the case. Perhaps there's some patient hesitancy among vulnerable populations, or perhaps some more legal obligations to adhere strictly to the guidance that regulatory bodies are providing. Similarly, we see here that patient volume is not recovering as quickly in public health settings. To orient you to this rainbow, the purple, red, orange, and yellow all represent patient capacities less than or up to 50% of pre-pandemic typical. The greens represent patient volumes above 50% of normal, and black represents no change in patient volumes from typical. If you look at the bottom bar in both graphs, this indicates responses from the week of June 29th. The majority of public health settings are still seeing less than 50% of their typical capacity, while the vast majority of those in private practices are seeing greater than 50% capacity. Next slide, please. Great, thank you. Here we have collections. The color scheme is similar, where the purples, reds, oranges, and yellows indicate a lot of room to get back to normal, and the greens are getting closer to normal. You'll also see in the public health graph that there's a portion in gray, and this is not necessarily insignificant. Those are the not sures. So with many dentists in public health settings being primarily focused on clinical care rather than in administrative or leadership roles, they might not be as privy to this organizational or operational information. So collections did not drop as much in clinics as they did in private practices during the shutdown. In addition to patient volume not dipping as low in public health settings, we of course know that the financing structure is very different in public health settings compared to those in private practices. So there are many reasons why we may be seeing this discrepancy. Now we'll look at dentist employment or payment status. We'll get reoriented. The top set of bars, as usual, represents those in public health. The middle set is dentists in private practice, the entire panel. The bottom set of bars is the subset within private practice of non-owner dentists. Given that non-owner and public health dentists are most commonly under employee status, we figured this was a good comparison. So we'll look closely at the top and bottom graphs here. At the times in which we've surveyed public health dentists, the majority remain employed and are being paid. At the end of June, 90% of employee dentists in public health settings were being paid fully, as opposed to about 2/3 of employee dentists in private practice. And among those who were not being paid, either in public health up top or non-owner dentists in private practice on the bottom of the slide, a much greater proportion were receiving unemployment benefits in health centers and clinics. That is indicated by the green bar. We don't know why this is, and if there are any insights from the audience, we certainly welcome you to input that in the Q&A. Here we're looking at PPE supply based on approximate number of days of inventory. Our 4 categories of PPE include N or KN95s, surgical masks, face shields, and gowns. There are no stark contrasts between public health and private practice settings here. As with collections, there's a not insignificant proportion of those in public health who are reporting that they're not exactly sure what their PPE supply looks like in their workplace. Again, this is more employee dentists who might not be as abreast of the procurement status or specifics of the PPE supply. We recognize this is a fluid situation and might be changing as we speak, so we'll discuss some of these issues with the panel. All right, we've also asked about the number of operating hours compared to pre-pandemic levels. A new color scheme, so let's get acquainted with it. On the left, we see light blue, and this represents those that are open fewer hours before. On the right, we see dark blue, those that are open more hours than before. The royal blue sandwiched in the middle takes the cake here for both private practice and public health settings, indicating that most have not changed their number of hours of operation all that much. However, those in public health settings might be a little less flexible. There's a greater proportion that are open fewer hours and a lower proportion that have expanded hours. This is something we'll discuss with our panelists. Perhaps it's due to lower patient demand, staffing shortages, organizational capacity limitations. We'll see what they have to say. Now let's take a look at number of patients seen per day. Please note that these graphs are not to scale. You'll see in public health settings, they were previously seeing a max of about 62 patients per day, while private practices were seeing 32. This does not account for the size of the clinic or practice in terms of number of staff members on the dental team or number of operatories. But take a closer look at the change from the pre-COVID to pandemic figures in both settings. Maximum patient capacity has dropped by nearly 50% in public health settings and only by about 1/3 in private practice. Now we'll get into a couple of our questions of the week. This has only been asked of those in public health settings, hence the lonely graph here. We inquired whether dentists in these settings had a mobile program in their center or clinic. Over half of the respondents report that their center or clinic does typically have a mobile program, as you can see with the red and green portion of the bar. However, the vast majority of these programs, the red portion, have not been reinstated. All right, now we'll flip over to teledentistry, everybody's favorite topic of late. This slide is comparing public health dentist responses in wave 1 and 2. So both the top and bottom graphs here represent those in public health settings. The majority of centers and clinics are using teledentistry, as we see by the green portion of the bar. And the service offering seems to be holding steady. Again, top is early to mid-May, and the bottom graph is end of June, and there is not much change here, as you can tell. Now we'll compare teledentistry use in centers and clinics to private practices. The polling dates for these questions are a little bit different between the two panels. We've asked about teledentistry in both waves of the public health panel and in a couple of the waves for the private practices. The proportion in private practice who had adopted teledentistry during the shutdown is much lower than in public health, and the proportion in private practice offering teledentistry continues to drop, as shown by the shrinking green bars on the bottom graph. Again, there's a lot of room for discussion here, especially in terms of how health centers may be using teledentistry differently than those in private practices, perhaps for services outside of or beyond a limited problem-focused exam. The last items we'll cover here are insights from consumer data. HPI has partnered with a leading consumer research firm, Engages, And at HPI's request, they've added dental-related questions to a nationally representative household survey that they run every 2 weeks. This gave us the ability to get a better sense of how the public is viewing dental care visits during the pandemic. We have a few highlights to share here. This slide may be familiar to those of you who have tuned into prior HPI COVID Impact webinars. Engages asked this following question for a number of activities, which now includes visiting a dental office. Which of the following conditions is closest to your current point of view? The 4 response options were: 1, I've already gone to the dentist. That is shown in the darker green in the northeast portion here at 20%. Then we have those that say they're ready to go, the lighter green on the southern portion of this pie at 52%. Next, we have those who would be willing to go as long as they have assurances that it's safe. That's the yellow in the northwest at 14%. And finally, we have those who say, nope, I'm going to need a medical breakthrough, a vaccine or treatment before I head back to my dentist's office. And that's the red or western portion here at 14%. So what does this tell us? Roughly 3/4 of our typical pre-COVID patient population is ready to go or already are going to the dentist. They have essentially no issues with it. This is interesting because it matches what we've seen in the private practice in terms of patient recovery being right around the 71-72% of people. Everybody in this pie are those who have gone to the dentist in the past year. These are dental utilizers. They are our patients. So again, those yellow are the assurance seekers, the not quite ready yet, but maybe with additional assurances from CDC, their local dentist, friends and family, who knows. What we take from this is that at least in the short term, the upper bound on patient volume is probably right around 85 to 86% of what we saw pre-COVID. Everything but the red. Again, the red are those very cautious, risk averse, those who need a vaccine or treatment before they'll go back to the dentist. We're approaching that 85 to 86% patient recovery rate, at least in the private practice panel. All right, so to quickly summarize before we get to our panel, during shutdown, public health settings were less likely to close. Collections didn't drop as drastically as they did in private practice. And from some qualitative responses we saw, we know that many dentists in public health settings are taking on new or additional responsibilities in their workplaces. They might be administering COVID testing or working to establish new community partnerships to ensure that their patients are getting necessary care. In recovery, fewer FQHCs or health centers are operating as usual. Teledentistry is sticking, and mobile programs are not quite up and running again yet. Patient volume, there was a significant drop in patient volume in all settings, as we know. The maximum patient capacity has dropped by nearly 50% in public health and by about 1/3 in private practice. And in terms of patient readiness, we're seeing that 72% of adults are already very comfortable with visiting the dentist. We also expect that there's an upper bound of about 85 to 86% of what we'll see in patient return from pre-COVID levels. So thanks again for tuning in today. I'll hand it back to Marko so we can get to our panelists.
That's great. Thank you, Chelsea, so much. Obviously, lots of key findings there. The key takeaways you summarized, fantastic. What I want to do now is let's bring in the panelists now, and let's go live. Welcome. We'll do a quick orientation of who's who in a sec. But again, I just want to encourage everyone. We do have Q&A coming in, so keep that coming. I'm going to kick us off with a few questions. But you'll see Chelsea there. Chelsea, raise your hand just so everybody knows who you are. Fantastic job. Thank you for walking us through the key findings. And here again, we're joined by Elizabeth Simpson and Sam Wakim. There you are. Before we kick off, can I start with you, Liz? Can you just tell us a little bit more about yourself?
Sure. My name is Elizabeth Simpson. I am a general dentist with Meridian Health Services. It's a large FQHC system and has many clinics throughout the state of Indiana. We have 2 dental clinics that are currently functioning, one in Elwood, Indiana, and one in Anderson, Indiana. And I'm in Anderson today.
Okay, and thank you. We're very privileged. I know you've had a busy day already, and you're between patients, so thank you so much for joining. Sam, same back to you. Can you tell us a little bit more about yourself?
Sure. Hello. Thank you so much for having me on this webinar. So I'm Sam Wakim. I'm the Chief Dental Officer for Zufall Health Center. Likewise, we have a number of sites all over New Jersey. We have 7 that have dental and 9 total sites. And we just last week reopened our 7th site for dental services. So we serve a number of patients all throughout northern and central Jersey. We focus on special populations, including residents of public housing, homeless patients, farm workers. We have a number of Rhine white patients that we provide treatment to, as well as, of course, children and the elderly.
Great. So thank you both, and thank you, Sam, for joining. Let me just ask, is there something that really surprised you from these results? I'll start with you, Sam. Or something where you're like, yes, absolutely, I'm seeing that day to day.
Yeah, I think I felt reassured that I'm happy to see that the other health centers are kind of rebounding at a slower pace, like us, compared to private practices. I think we have a number of challenges, like Chelsea mentioned earlier, that we probably have to overcome, like a higher regulatory burden that we have to meet, and a number of factors that kind of slow our recovery. So I think I'm reassured to see that there's a slow recovery all throughout the public health setting, and I think just by the nature of who we are, the patients we serve, what we do, I think that makes sense to me.
Okay. Same to you, Liz. Something that surprised you or confirms your experience?
A couple of things. Same thing where I was relieved to hear that other health centers are sort of slowly climbing back up to normal. When we reopened at almost full capacity, we had a couple of meetings that went over our patient numbers, and every time we talked about it, our director would say, we're going to get back up to our pre-COVID numbers. And with the type of patient population that we serve, any one little thing can happen in their day-to-day life that keeps them from coming in. And for many of our patients, they work the jobs where they are hourly employees. They can't work from home. And so now, they have a lot of other things that they're trying to get in line before they can come back into the dentist. And so I think as we continue with things at the level they're at in our outside lives and in public with things getting re-shut down, I think it's going to continue along the same trend for our patients, that they have a lot of struggles to get in pre-COVID. And so now it's even harder for them.
Okay, so let's dig deeper into that. So one of the things Chelsea showed through the data, right, is that the patient volume rebound is not as dramatic in public health settings versus in private practices. And now you're both alluding to some possible reasons, but I want to push you on this, right? So is this an issue of, I don't know, you can't see as many patients because of the new care protocols and OSHA requirements and ADA recommendations? Or as Liz was alluding to, well, it's also primarily the patient side, right? Is that this is already a population that has challenges in the best of times, let's say, right? And now you're adding a pandemic that's disproportionately affecting people of color and low-income people. And that's kind of the FQHC patient base, right? So I'll turn it to Sam on this. So can you shed, like, if I ask you directly, is this primarily a supply constraint, or is it that the population is just not willing to come back? Why is the patient volume not rebounding?
Well, I mean, at this point, for us, it's a matter of capacity. I mean, we have still half of the staff that we had prior to the pandemic. Okay. So we're bringing people back incrementally, and I think we're limited with PPE tremendously. So I'm hoping that we're going to get some N95 masks tomorrow. That's what my vendor promised me. I've been waiting for PPE, for a while, and it's like in 2 weeks, it's coming for months, and hopefully it will be here tomorrow. But that's kind of one of the main limiting factors for us, because OSHA said that for any aerosol generating procedures, you should have an N95 or better respirator. So based on that, whether the patient is well or whether they're suspected of having COVID. So based on that, I think we want to make sure that we have proper protection for our staff. So we're kind of moving cautiously, making sure that we have a couple weeks of supplies for the staff that's there. So.
Yeah, I want Liz's reaction too, if you have anything. But first, Chelsea, one of the things you showed was that the maximum patient volume, right? So in the survey, we asked, what's the maximum patient load you could see pre-COVID, and what is the maximum patient load you could see today? It wasn't what is your actual patient load, but the maximum, right? And can you just refresh us what the conclusion was? It was basically that capacity dropped. Well, I'm not phrasing it right. Can you give us the summary?
Sure. Yes. Yeah. So in public health settings, it seems that capacity has dropped about in half. Whereas in private practices, what we're seeing now is that we're at about 2/3 what our prior capacity was. That's as of the end of June.
So I'll start with Liz here. Why? Why would capacity constraints kind of bite harder in public health settings versus private practices?
So, with all the grants and all the financial part of FQHCs, there's a certain number of patients that you have to see in a day. So if you originally had 7 patients scheduled in the morning, 7 in the afternoon, and you needed to see 14, then that was sort of the goal for the day. And now, when we first went back, the recommendation from CDC, I believe, was that a room needed to sit for about an hour before you could see another patient in there. So if that's the case, you can't book your normal 7 patients. You've got to book a certain amount of time to let the room sit, and then you can only maybe see 3 patients. Well, then the recommendation was updated. And so it only had to sit for 15 minutes. Well, that is still you're always losing chair time just for the room to sit and to be able to have people come in. So right off the bat, when we walked back in the door, we went from a total number of possible appointments to half of that. And so that it's going back up slowly a little bit more when it's changed just for the cleaning the room. So that changed it right off the bat.
But I believe, and correct, I believe CDC even removed that 15-minute requirement recently in the last couple of weeks. Okay, you're nodding your heads. Okay, Sam, let me be more provocative, right? Do these data signal that FQHCs are being safer and more cautious and taking more precautions, and private practices maybe aren't, and that's why they can see more volume? Is that a reason?
I think we have to be. I think we're really striving to create a safe environment for our staff, and our patients and our community. You have to remember that, FQHCs are typically geographically located in underserved areas that have been hit harder than other areas. Our patients have been disproportionately affected by the pandemic. So we have to create, a sense of safety for our patients and our employees, so that, we protect everybody at the health center. So I think the answer is, to me, is yes. We're working very hard to move incrementally to make sure we have everybody's input and everybody feels safe and is, we're having an educated conversation about what facts we know. Again, early on, we didn't have as much information as we do now. So as information accumulates, I think people are trying to be educated and logical and not just act out of panic and fear. But I think certainly having a safe, clean environment, that makes everybody feels comfortable is an important priority to us. So we're doing a number of things, towards that we could discuss later as well.
I think it's a very important point you raised. Sorry to cut you off. I'll come back, Liz. But Sam, it's a very important point you raised that I hadn't thought of, right? Like the patient base is on average different. In fact, they're higher risk for COVID, right? So maybe you do need. Go ahead, Liz. If you have to deal with that, go ahead. We know, right, that if the patient is higher risk, maybe that does limit the time, or there's an additional constraint there. If you do have to take extra precautions. That's a very, very important point.
Yeah.
Okay.
And I don't want to stigmatize the patients either. I mean, I think, I don't want to say that they're, higher risk because they are patients. That's certainly, certainly not true, because I feel overall our patients have been extremely good at, following social distancing, wearing masks. I think I'm very proud of our community and, as a whole, our patients and our employees, everybody's been, extremely, have done everything they need to do to
Yes. I didn't mean it that way. I meant more like lower income or from maybe higher prevalence areas of COVID, et cetera, more comorbidities like diabetes, chronic conditions. I meant it in that way, not the behavioral sense. So just to clarify. Liz, anything on that in terms of the why the capacity would shrink more in FQHCs versus practice?
One of the things I actually thought of too, a couple of things, was with the patient population that we see, we don't know how many of our patients were sick. And so, we could be waiting on people to recover and we have no idea that they were sick. So that's one thing. I think that one of the differences too with somebody's private practice is they can make the decision for their office on the CDC recommendations if they want to adhere to them, or if they want to open up business as usual. They have an income at their disposal in a different way than we do. When, you're a director there and, with my director, we have a list of things we want to get, but they have to present to our CFO the list of things. And if we're like, well, we would like to have a couple more extra oral containment units, and we need this and we need that. And they have to look at the budget. Whereas, I haven't been a practice owner, but you add that to your loan for your office and, you can go back to work. And so, the financial part in getting back to full capacity is different.
Right. Okay, good. Chelsea, anything to add on this? I mean, you worked in lots of different settings as well.
No, I mean, I think they've covered it. I don't have anything of value to add.
Okay. A couple of things I wanted to do, and then we'll open it up to Q&A. Teledentistry and mobile services as well. So one of the things Chelsea showed was teledentistry seems to be more prevalent in public health settings and seems to be sticking. Whereas in private practices, it seems to have been a temporary measure during the shutdown. Sam, I know you have mobile programs as well. Can you tell us why? Why is teledentistry more prominent? And then I guess I would say, it is a good thing. We don't need to say is it a good thing or a bad thing. But why is this not taking off more broadly, I would say?
I think it does have its limits. So I think early on, we did a lot more teledentistry because patients were actually afraid to come out of their house And we had to, kind of limit how much teledentistry we were doing, because if we gave somebody antibiotics, once or twice, then there's no way we're going to give them antibiotic again. There's risk of developing C. diff or other deleterious health effects. So we wanted to have patients come in and be treated. And, we used teledentistry initially because we had to, patients weren't coming out, a lot of them. And then I think it kind of evolved. The dentist didn't want to, not have an x-ray, not be able to examine the patient. So there was less of it as time progressed. And now we're kind of looking at the possibility of using it for managing some of the same-day emergencies. Because, again, before COVID, we used to have our waiting rooms jam-packed with emergencies who are waiting to be seen. And that's going to be much harder with social distancing. We can't have people just hanging around, in the waiting area. So we're trying to figure out how much can we use teledentistry for the purposes of, addressing concerns of patients, certainly who have been to the center recently and have recent x-rays. We're trying to do as much as we can with teledentistry just to manage the flow and, maximize social distancing and decongest the waiting area. So it's helpful in those terms for the management of emergencies. In New Jersey at this point, teledentistry is only covered for emergency services. So that's kind of what we're limited to. And then with regards to the mobile services, again, that's dependent on schools reopening. We did a lot of work with the schools, Head Starts, places where there's a lot of congestion. So I think we're kind of at the mercy of what happens with the schools and how much we could do with regards to mobile services.
Liz, anything to add on that? Are you using teledentistry in your facilities?
We did sort of a form of it when we were never completely shut down. What we would do is we would have emergency patients come in, and since we were trying to preserve PPE, our assistant would take a pano so they wouldn't even have to do an intraoral x-ray. And the dentist, my colleague and I, we would stay in our office, we would look at the x-ray, and that was it. And so as soon as things open back up, we don't do that anymore.
Okay. All right. Good. Look, I have some more questions. Chelsea, sorry.
Yeah,
please.
sorry. I just thought I'd add one other quick note on teledentistry that I've heard anecdotally. This might relate more so to those working with pediatric populations, but I think some are now turning to teledentistry as a way to do some patient and family education. So it, of course it becomes difficult. There's not necessarily much reimbursement there, but I think in some public health settings that folks are getting creative with how to use teledentistry and expanding the scope of its possibilities.
Chelsea, thanks for raising that, because our data last week, again, from our private practice panel, we ran the numbers by specialty. And pediatric dentists, just as Chelsea's alluding to, they were by far the most likely to be continuing to use teledentistry. And then the next specialty was orthodontics. So pediatrics and orthodontics seem to be the fields right now that are most likely, like a third of practices almost, were using teledentistry. So it makes sense given what Chelsea said. Look, we got a lot of questions coming in. I'm going to cut short our part here. Let's bring in Adriana, who's been carefully monitoring what's going on. There you are. Hello, Adriana.
Hi. Good morning. Good afternoon.
Yeah, walk us through what are some of the themes coming through with the Q&A.
Okay, thank you so much for everyone for submitting all your questions. And besides questions, there are a lot of conversations going on in the Q&A too. So thank you for that. I'm sure all the entire audience is benefiting from that. So to start, Marko, a few people had questions about the survey itself. So maybe we could start with that. So one question was, how do we define public health setting for this survey? Who's included in this sample?
So Definitely, we had so first of all, the sampling was done through basically snowballs. We had promoted this on various public health organizations through listservs. We had our own list of who works in FQHCs and health centers. But it's basically FQHCs, health centers, hospitals. Adriana, do you remember if it was dental schools?
So I just sent a question to our colleague, Matt Michelson.
Okay.
And the question in the survey was, so you would select dentists who are in FQHCs, non-FQHC health centers, city or county health departments, and let me see what is this last one, private practice that has an official collaborative relationship with a health center. So those are the types of dentists that filtered in.
Okay. So with that first round of, let's say, snowball sampling, we also asked people, are you interested in remaining for follow-up waves of the survey? There was some subset of those that were, and they got the second round of the question. So that's basically how we created the sample.
Okay, great. There are a few direct questions to the panelists, so I'll read a few of them and then I'll go into the group of themes that came about. So Mark asked, panelists, how would you characterize access challenges for your patients? Do you mean longer waiting lists, more acute cases, new patients due to economic troubles, etc.?
Okay. Who wants to start? Liz, do you want to take a crack at that?
So, one of the definitions of our clinic is that when people sign up, they have to provide financial information. And so we put them on a sliding fee scale that's based on their income and their family size. And if they're wherever they fall on that sliding fee scale, that indicates how much they have to pay. And so many of our patients are at 100% of coverage for what they have to pay. And so I believe, and Dr. Sam, you can correct me if I'm wrong, I think it means they fall like 400% below poverty, or whatever the percentage is. And so when we're talking about, the hurdles they have, their income right off the bat is going to be a hurdle.
Yeah, I would add that, we are expecting to see more uninsured patients. We already see increased demand. There's obviously a lot more people on unemployment. There's a lot more patients that will need our services. Unfortunately, we're already seeing that. I think, combined with the reduced capacity, I think the question was, exactly right. When you have reduced capacity and higher need, I think we are going to end up with a backlog and more acute care. We already see a lot of emergency care, and we do a lot of urgent and emergency treatment as it is. But I think we're ultimately going to have to reduce our services or reduce our scope to be able to keep up with the increasing demand for services.
And we have,
more basically, sorry, go ahead, Liz, but I was going to say, do you have a wait list? Like if somebody wants to come tomorrow, can they see you, Sam? And Liz, same thing, like that.
We typically don't have a wait list, but we always take walk-ins.
Okay.
So
and you're still doing
people,
that now.
Yeah, we're still doing that. We've been doing that the whole time.
Okay.
So we're definitely limiting new patients. We cannot.
You are, okay.
Yeah, cannot take in new patients. We're worried about serving our current existing patient population. So unless it's an emergency, we're really limiting new patients at this point.
Okay, great. Thank you both.
Thank you. A couple more questions for panelists too, and then I'll go move into the themes. So a different Mark asks, what percentage of visits during COVID were emergent versus periodic visit at the FQHCs? And Maria asks, do you see that the vulnerable adult population is returning faster than the children population? And she mentions some children dental needs were great pre-COVID.
Sam, do you want to start this time, and then Liz?
Sure. I have a terrible short-term memory, so I already forgot the first question. You might have to
first question was, I get it. First question was, what was the percentage of your visits that were emergent versus periodic visits at FQHCs during COVID?
Yeah, so I think it's a small percent. I would say 15% probably of our visits were emergency visits. We depending on the site and the size of the site. Before COVID, we had a certain number of walk-ins every day. With regards to the children, I think we've made an effort to concentrate on getting them back in after the once we started reopening. So we focused on getting children in first, multiple reasons. One of them being that it was easier for us to work on them and not generate aerosols, do a hand cleaning and get sealants on. We switched to glass ionomer sealants for the most part. So we're not generating as many aerosols. And we kind of shifted our workflow a little bit. I think we're encouraging people to do long-term temporary fillings if possible, seal over decay, incipient decay if possible. These are all things that are evidence-based practice based on the clinical evidence from the ADA, the journal. So we're trying to be a little bit creative in making sure we meet children's dental needs without delaying care and again having to deal with things that might blow up later on.
Yeah, Liz?
Just to make sure I got the question right, they're asking what percent during the, did we see, it was only emergencies that we saw. We didn't see any of anything else. And we weren't doing treatment. So we would basically have the patient come in, do a quick exam, do a prescription if necessary, and then have them schedule them to come back.
Sorry, so I got the question wrong there.
No, but you answered a good question. Don't worry about it. That was because I want to ask
two first. So.
I want to ask Chelsea and Adriana. Give us only one at a time. We don't have the cognitive capacity here. But Chelsea, let me bring you in. Sam's raising a really interesting point. So could this potentially shift to more prevention, less using the handpiece, even more silver diamine fluoride, glass ionomers versus, I don't know, traditional?
Yeah, I think.
Is that good?
Yeah, definitely. That's a lively conversation in our public health dentistry realm right now. And I think that although nobody would have wanted this to be the motivating factor, I think there are a lot of us in the dental community that really hope we realize the value of these preventive practices more so than we have in the past. If it's okay, can I jump back and chime in on a previous question as well?
Yeah.
In terms of barriers, one thing that I've been really curious about, and I don't have experience with right now, but is transportation becoming more of an issue. I'm sure, of course, that's dependent on where you are. And yes, a lot of public transportation is operational again. But I think for a lot of our patients, in these settings, it could continue to be a major barrier, more so than it was perhaps in the past, just because of the associated risk. So I'm really curious what we'll see in terms of that barrier. I know there's some really innovative stuff going on with, like, for instance, Lyft is partnering with Medicaid and some areas to think about how to address some of these social determinants and reduce barriers. But again, I don't have personal experience, but I'm just curious how this era is affecting the transportation barrier.
Anything innovative on your ends, Sam or Liz, on partnering with Lyft or addressing transportation? Or
no, at our smaller clinic, we have a lot of patients that walk. So. Okay. Which is a good thing, but then if the weather's bad, they may not walk. And I know that when things started reopening and when things were really shut down, Lyft, Uber, I think Medicaid transportation, they weren't giving people rides. So, I think having to maybe have masks for people going, there's always these little steps where if you don't know where to go to get a mask, then you can't get transportation that requires you to have a mask on. So these are just a lot of things that we may not think about for ourselves that our patients have to deal with.
Sam, hold your thoughts on this. Let's get to some other, because I know I'm conscious of time here. Adriana, some bigger picture ones.
And Thank you for covering the transportation topic. There are quite a few people mentioning that could be one issue with access to care during these times. So a couple comments and questions about PPE. So Carol Ann said, and this is a comment, and I'll follow up with a question from another person. So Carol Ann said, in public health, we rely on FEMA for PPE supplies. In my area, there's still a problem getting certain supplies, such as N95, and that staff have been fitted for. We're currently sent anything they have available, and if we don't have the correct supplies, we cannot work. So that's one question about access to PPE. Maybe you could share your experiences. And then Gary also asked, how is the public health sector handling the higher costs of PPE and costs associated with COVID?
Let's start with the second one. I think because Chelsea showed us, we can talk about the personal experience, but I mean, PPE, definitely a shortage, well, I don't know shortage, but more constraints are coming given the surge in cases. So I think we can agree this issue is going to probably worsen. The ADA is doing a lot, working directly with FEMA, making sure dentistry is kind of on that priority list, and a significant flow, I don't have the numbers, but significant share of masks has been allocated and is in the pipeline. But the second part, costs. I guess, what can you shed on this? I know in the private practices, there's a debate on, should we just charge patients? Should the insurer pay for it? Should the practice just swallow it? What's happening on your end in terms of the cost of PPE? Let's start with Liz, maybe on this one.
I'm not completely sure about the cost part. I think Sam, as a director, you could probably answer that better.
Fair enough. Sam?
Yeah, so I think we wanted to stick with our big vendors because, again, we didn't want to get price gouged. That's why we've been waiting for, a number of reasons. That, and also we wanted to make sure that we're getting good masks. There's been a lot of counterfeit stuff that's been sold out there for ridiculous amounts of money. So we wanted to make sure we're getting our supplies, from a reputable vendor, and they're legitimate. They're going to do what they're supposed to do. So we have not paid much more than we would have paid before for the N95 mask. But that being said, the N95 mask is certainly much more expensive than a surgical mask. So I think we've had some grant funding that's been helpful to us, but that's a factor going forward, is the cost of the PPE, and being able.
But bottom line, you're absorbing it basically,
right?
And you're saying it's not a huge change in price, right? Okay, right. Adriana.
So Mark asked, at FQHCs, has daily reimbursement changed during COVID?
Great question. Has your reimbursement rate changed at all? No. Okay, Liz. No. Okay. Nope.
Unrelated question. So, is there any data on dental practices and in public health setting practices incorporating COVID testing for patients?
Chelsea, anything in our surveys?
We don't have any quantitative data on that at this time, unfortunately, but we do know from some of the questions we've raised in both waves that there are a lot of providers who have been pulled into new responsibilities. So that might be COVID testing, it might be, offering support to their medical counterpart in some other way. And I think this gets back to the dental capacity again. Are dental staff being used for other purposes at this time, and have not been able to get back to dental patient care for that reason. But yeah, very clearly there are a lot of people in public health who are expanding their scope right now in those sorts of ways.
So let me ask it a different way. If we had testing available in your FQHCs, both you, Liz and Sam, and I don't know, let's assume it's a 15-minute result. Do you think this would allow more people to access care, or would it just change what you do in terms of PPE? Like, I'm trying to think, is there a social good here? Would testing capacity ease the patient side's concerns, or is this more on about, okay, who do I put PPE, normal versus enhanced? Like, how would this change access? Sam?
Well, we are, we are doing testing. So we are in the process of training our dental staff on doing testing.
Okay.
Yeah, so we just recently got the Sophia rapid test machines from Quidel. So we got them for all of our dental sites, and we are training our staff to do the rapid testing. And so with that comes the, kind of trying to figure out the workflow and separating aerosol generating procedures again from non-aerosol generating procedures, again, to guide PPE use, and also to make sure that we're protecting everybody, and everybody feels safe and everybody feels comfortable, and then we could do as much as possible for the patient. So testing is a great thing. I mean, again, aside from its uses in the dental setting, the obvious benefits of helping us treat patients safely, it's also great for early detection and making sure that the community transmission numbers stay low, and we detect and isolate people early. So I think it's got a great role in dental public health settings. I think it's a great way forward for us. And as we're building slowly, I think we're looking at sustainability. So we might be moving slower than private practice, but whatever we're doing, I think we're confident that we'll be able to sustain and maintain the level of services. So hopefully, with all these measures that we're putting in place, we won't be going, backwards as much.
Okay.
Hopefully the numbers will help too.
Liz, anything to add on testing?
We aren't doing it, but I could see the system that I work for asking us to do it for multiple reasons.
Okay, good. Adriana, maybe one more?
Yeah, okay. So one last question from Amanda. Do either of you envision, or when do either of you envision that you start seeing more patients? She is in a FQHC in DC on half schedule, and she has no timeline to determine when she would be back at 75%. So maybe to paraphrase, when do you feel you would be back at pre-COVID levels, or will you be back at pre-COVID levels?
Or even, are you now in a flat line, or do you think things are going to keep growing? Talk about the future, what you see.
I think, like we said, we're growing slowly. I can't foresee that we'll get back to pre-COVID levels until there's a lot of other things in place, in our community and in our country at large.
Sam?
Yeah, I think, again, having the right PPE, having the right supplies is going to be helpful. We are, again, unfortunately, because of the changing nature of what we're doing, I think there's a lot of non-aerosol generating procedures that, we have to do. So there's plenty of partials and dentures, unfortunately, that patients will need. Patients have got a lot of extractions over the past few months. So I think we anticipate being busy. So in terms of numbers, I think it's going to be busy. It's just a matter of increasing capacity, and that's going to be dictated by making sure we have all the stuff that we need to be able to do that and bring people back on.
Chelsea, from the data side, what's the new normal looking like on the private practice side?
Yeah, on the private practice side, I mean, we're in the upper 70% of pre-COVID levels. So, but I think we have hit that plateau. So it'll be interesting to see if, our hypothesis based on the consumer research holds true, and if we continue climbing up a little bit, or if we really are in this plateau, and do we see a dip in it because of now the resurgence of cases in certain parts of the country. So yes, private practices are seeing more patients. As we've discussed, the recovery's been a little bit faster there.
Okay, so we're going to do a monthly wave of this survey, and let's see what the next round shows. We obviously should have allotted more time for this. I see about 90 questions, Adriana, through the Q&A.
Yep.
I'm sure we're just scratching the surface, but thank you. And I'm just going to put both Liz and Sam on the spot. Can we have you back for another one of these maybe in a few weeks?
Sure.
Sure,
Okay,
anytime.
because I feel we're just getting into this. And note to self on the HPI team, 90 minutes next time. But with that, I want to respect people's schedules. Thank you all, Chelsea, Liz, Adriana, Sam, and Sylvia in the background. And all of you, I'm sorry we didn't get to all the questions, but we'll do better next time and have our panelists back and look forward to what the next round of data says. So thank you all for joining and we'll see you further up the road.
Thank you for having us.
Thank you.